Hello, this is Dr. Michael Riddell speaking to you from York University, recording this webinar on technologies supporting exercise adherence and control in diabetes. Just a bit about me. I am a researcher who happens to live with type 1 diabetes. I have a university lab that looks at how exercise and stress impact metabolic control in animal models of type 1 and type 2 diabetes, and also I run clinical trials on trying to maintain the best glycemic control during competitive exercise and sport in patients living with type 1 diabetes. I myself have been living with the diagnosis of type 1 diabetes since the age of 14, and I've had the privilege of doing some pretty incredible treks with others living with type 1 and participating in a hockey program called D-Skate that tries to empower young children who've been diagnosed with type 1 diabetes to take care of their diabetes and to reach their sporting and competitive desires. I know firsthand that controlling glycemic control around exercise can be quite challenging while living with diabetes. Last summer I did a trek called the Tour of Mont Blanc, where there was a number of us living with type 1 diabetes embarked on a 6-day trek trying to manage our glucose control while hiking for about 6 to 7 hours a day through the Alps and enjoying the different foods and cuisines of that part of Europe. I found it interesting that many of us with diabetes can eat the same type of breakfast in the morning, have about the same total daily dose of insulin, but then when we embark on a trek like this one, we'd have a different glycemic response. There is certainly a unique pattern of glucose responses to exercise. In today's webinar, we'll talk a little bit why I think we have these individual patterns of blood sugar responses to the different exercise and sports we do if we're living with diabetes. We've learned a lot from various athletes who are living with a diabetes diagnosis. We will be sharing some data from Team Novo Nordisk, an all type 1 diabetes professional cycling team. We see in the professional NFL football league, players like Jay Cutler performing very well with their diabetes, hockey players like Max Domi. We even have some Olympic athletes that are now training for the next summer games, including Mandy, who's on the US national cycling team, and a pro golfer named Michelle, who is on the LPGA circuit. There are also a number of former athletes who are now living with a diagnosis of type 2 diabetes and are still quite accurate. And it's empowering for us to learn about how regular bouts of exercise allows them to manage their type 2 diabetes with better control. I just want to first speak about preparedness for exercise. We can learn from Sebastian Sasseville's journey, which was a 7-day desert race covering 155 miles, that if you have type 1 diabetes, you just can't go out and do a sport like this without considerable preparation. Just thinking about the stuff that he had to pack and to make sure that he could carry with him on his trek, we realized that food and insulin supplies, lancets, glucose meters, insulin pumps or backup insulin pens are kind of critical for being prepared with someone who's going to do exercise. And I know this is a bit of an exaggerated list. We don't need all these things when we go for a 30-minute walk, but we do have to have some level of preparedness. In today's session, I'll speak to some of the key elements about preparing for a 30-minute bout of exercise, a 1-hour bout of exercise, or even longer. So thinking about our challenge last summer in the French Alps, we learned that you had to respond to different types of cuisine during a trek. When someone with type 1 diabetes is in a new situation of food and nutrition, they have to be able to adapt and be able to count carbohydrates, estimate the type of fat and protein that may be in foods, and dose insulin accordingly, not only to the carbohydrates and fat and protein in the meals, but also to what they anticipate will be the exercise for the day. And we saw lots of challenges in this trek of ours. Most of us on the trek did use continuous glucose sensing, and I'll speak today about why I think that's such a valuable tool in the arsenal of diabetes management, particularly around exercise and sport. Oh, by the way, we do have to bring supplies on a trek like this. You can't just go to a corner store when you're in the Swiss Alps and buy some carbohydrate. If your blood sugars are trending low, you have to carry it with you. And on this trek, I know how much carbohydrate we had to bring because I had to carry it. And during this 6-day trek, we went through 19 kilograms of dextrose tablets just treating hypoglycemia. So there's a considerable amount of preparation that had to be taken, and that's even after adjusting insulin to the best of our knowledge to try to prevent hypoglycemia. And I'll come back to some of the insulin adjustment strategies that we implemented on this journey. So what are some of the key factors that you need to know for this webinar? Well, we know that exercise is critical for health and fitness in diabetes, both type 1 and type 2. We know that people who are regularly physically active tend to live longer with fewer complications from diabetes. And I'll speak in a few minutes about what the exercise prescription should be for those of you who have patients who are living with either type 1 or type 2. We also want to enforce in this webinar today that there are several technologies that might facilitate exercise adherence so that our patients are more physically active, and also technologies that can facilitate improved glycemic control around exercise. So the recommendations for the total volume of exercise that we should be doing each week if we're living with a diagnosis of diabetes, whether it's type 1 or type 2, is found in a few different resources. The one I'll share with you right now was published last year in the Standards of Medical Care for Diabetes. These guidelines include 150 minutes of total physical activity minutes per week. This is structured physical activity that lasts for bouts at least 10 minutes in duration that allows our heart rate to rise. It's okay to break up those 150 minutes into short bouts throughout a given week. And in this example here, you can see that you could have a little bit of housework. You could have just some habitual movement around work or home through stair climbing. You could undertake some brisk walking. You might be engaged in some sort of structured sporting event like a soccer game. You might have some cycling during the week, and you may do a structured workout that could include 30 minutes of exercise on a treadmill or an elliptical machine. All these add up to the total minimum requirements of 150 minutes per week. On top of that, we also recommend 2 to 3 days per week of some sort of resistance exercise. Shown here are some resistance bands, but this exercise could also take the shape of weightlifting or using your own body weight as resistance to try to increase our muscle mass and strength. We know that being regularly active with diabetes is as important as being on a healthy diet, and it's almost as important as trying to replace insulin in the body physiologically. And it's also worth mentioning that we now think that glucose monitoring is kind of a key component of our control, both for insulin delivery, but also for exercise management and for food management. Historically, one of the first individuals that discovered that exercise can lower glucose concentrations in diabetes was a physician by the name of Dr. Lawrence. Dr. Lawrence had been living with a diagnosis of type 1 diabetes for a few years, and when he finished medical school, he undertook a study in which he tested his own blood sugar levels after injecting insulin and remaining sedentary on one occasion. And you can see here in this graphic that the blood sugar dropped from about 250 milligrams per deciliter down to maybe 175 milligrams per deciliter in a couple of hours. This was an older type of insulin, Toronto insulin. It did not have a very fast activity profile. But if you took that same dose of insulin, 10 units, and he added a bit of exercise, he liked to play tennis and do rowing, he noticed that that blood sugar would drop much more rapidly. So this was really the first indication that exercise can act just like insulin to lower glucose, because it increases glucose uptake into the working muscle and metabolism. And he was also the first to discover that sometimes this somewhat beneficial drop in glucose might lead to hypoglycemia if levels drop too low. And he did in this study stretch his exercise out to 2.5 hours and developed symptoms of frank hypoglycemia when his blood sugar dropped below 60 milligrams per deciliter. Now we know with continuous glucose monitoring that we can certainly see our glucose retrospectively and possibly get a handle on why our glucose might be uh, targeting out of range, uh, perhaps because of exercise. One of the challenges of CGM downloads is it's very difficult to remember which day of the week your patient was physically active unless they also have exercise logs. And some of the newer software used to examine CGM does indeed have exercise tags that then you can pull out to figure out if perhaps this one drop in glucose on August 8 was exercise related, or was it related perhaps more to giving too much prandial insulin at breakfast time. So this is something that's getting better, but still there's some need for improvement on how to tag exercise. And some of the research we're doing right now is trying to overlay heart rate with blood glucose trends to see if these reductions in glucose might be related to exercise, and maybe even some of these rises in glucose might be related to intense exercise in the form of competition. Technologies are certainly emerging that help me keep my glucose in control with exercise. I'm a firm believer of continuous glucose monitoring, and my son, Sam, who also happens to have type 1 diabetes, also uses CGM quite effectively to catch hypoglycemia in its very early stages if he's in a sporting event like a hockey game, and then treat that low before it disables him in a hockey game, or puts him on the sidelines because of more severe hypoglycemia. We both use hybrid closed loop systems. Sam currently is trying the Tandem Basal IQ, which has a forecast for hypoglycemia that can be used during exercise to turn the basal rates off before hypoglycemia develops. And I've been experimenting with a program called Loop, which allows me to customize exercise settings for my insulin delivery. And I've set one up here. You can see in the middle of the screen something called the OmniTime study, which was a study we published showing that if you reduce the basal insulin by 80% an hour before exercise and raise the glucose targets, you can pretty much eliminate hypoglycemia during exercise. We've also been doing some work with some emerging technologies to see if they will further improve time in targeted range during exercise, and that would be the use of a mini dose of glucagon before exercise, which we show has efficacy. And others have been using dual hormone artificial pancreas systems with glucagon and insulin to help have both a brake for hypoglycemia in the form of glucagon and an accelerator in the form of insulin if glucose is too high. But these are still at the experimental stage at the moment. Just having a quick look at one of my more recent glucose downloads in a program called Tidepool, you can start to see the strengths in my day seem to be overnight, as my hybrid closed loop system keeps my glucose in a nice tight targeted range overnight. And then you can see some of the challenges I might have at lunchtime with glucose rising slightly above target, but then that hybrid closed loop system bringing it back down to target. And then most of my glucose values, not all, but most, are staying within the targeted range for me between 3.7 and 10 millimoles. And this bar graph here shows that I'm spending about 76% of my time in target. I do have very minimal hypoglycemia now with the algorithms that I use for exercise, but I still have a little bit of time above target for some of the carbohydrate-rich meals that I consume after intense exercise, and we'll come back to some of the strategies that we can use to try to ameliorate that. I want to talk for a few minutes about some of the emerging technologies that I think help facilitate exercise adherence. And here we are at a time of the global COVID pandemic where people are having difficulty finding activities to do that are safe and effective inside the home, if you're limited in where you can go and get exercise outside of the house. So I'll just speak to that for a couple of minutes. Many people are gravitating to these apps that are either membership fee-based or some are complimentary. One that's getting a lot of attention is Peloton. Peloton was first developed as a program that you could do a stationary bike workout following a virtual trainer. And And certainly there was a lot of biking enthusiasts who were doing these 30 to 60-minute workouts following a very highly motivated trainer. The program now has an app-based format that you can watch on a computer or on a smartphone, and you can get coaching on running, outdoor running, indoor strength training, cycling, etc. And they even have very good boot camps or workout camps that can focus on building strength, stamina. And these are certainly engaging apps, but they're not diabetes specific. So there's very little information on how to manage your diabetes or what types of exercises are safe and more effective if you do have diabetes. An app that I engage in regularly is an app called Zwift. This is a competitive app in which you go for virtual bike rides or bike races. And what I like about this app is that there are different communities that you can join within the Zwift app. This is something that you set up on a smart device, perhaps connected to a larger television screen. And with an app that you can set up on your phone, you can actually pick different routes for a bike ride to go on. You can have fantasy rides in an island called Utopia. You can race the streets of London, England. You can do a bike race in Virginia, USA, and there's a number of different other routes that you can choose. And what I like about this app is that although you may be alone doing this app in your basement or in your training room, you are connected virtually with others that you may have a shared interest in. In fact, there's a very large cohort of type 1 riders that ride every Saturday morning that I join, and we all ride together, and we can actually communicate using our smart devices while we're in this social ride together. The app is very intelligent because it allows me to characterize what my avatar looks like. Here you can see me with a little bit of gray hair and some glasses on. And because I have a smart trainer that it's relatively inexpensive to set up, there's one shown here, the Wahoo trainer, it can show the power output or the work that I'm doing on the screen, as well as the heart rate that I have from a chest strap that uses Bluetooth technology to then communicate with the app. So this is a dashboard really that's quite valuable for any athlete if they want to characterize their performance, if they want to do a really engaging 30 or 60 minute or 90-minute workout. And on the bottom here, you can see your relative power outputs. So I do enjoy this app, but again, there's not recommendations on how to exercise or what to do if your blood sugar is low or high. With this particular app, it's more a social app that has a competitive element. So the last one I'll talk about is one that I think covers a lot of important ground. This is a newer app called Glucoseowned, developed by a fellow who happens to live with type 1 diabetes. And this app is what I think is the best evidence-based app for prescribing exercise if you happen to have diabetes. It's very engaging, and it has customized workouts for people living with type 1 diabetes, type 2 diabetes, or pre-diabetes. The beauty of this app is it's using evidence-based exercise prescriptions, which are very similar to the standards of medical care or the American Diabetes Association guidelines for exercise, in an engaging platform that has an educational element and some customization. I'll just speak for a minute about what this app offers. For type 1 diabetes, you enter in your insulin regimen, your insulin therapy, the foods that you eat prior to exercise, and estimates of the amount of insulin that you have on board in circulation, the prandial insulin that can often cause your blood sugar to drop. It also can focus your exercise workout based on your glucose concentration just before the exercise begins. And I really think that's really quite novel about this app. If your blood sugar is quite high, it can recommend a nice aerobic warm-up to bring your glucose down to target before you then enter into the stimulus phase of your workout. For type 2 diabetes, it also can gear the workout towards your fitness goals. If you have an interest in weight loss, if you have an interest in improving your glucose management, if you want to improve your fitness, etc. This app can then gear tailor its prescription to your own unique needs with diabetes. And it also takes into consideration your body weight, your level of fitness, and your glucose concentration that you enter in before you begin exercise as an educational and safety tool. There are a number of people using this app now, and it is currently free. And this dashboard shows that it's basically now has international coverage. There are people working out in real time, either watching live YouTube videos or using the pre-recorded exercises within the app. And you can take a look on the dashboard to see who else is working out with you at the same time. And they might have that same common interest that you could have, living with diabetes, trying to improve your fitness or perhaps your body weight. I've been using this app since the more recent download, and I like how it captures all of my workouts that I've completed. It stores my data, including my own CGM data, if that's connected through HealthKit on my iPhone. And it allows me to track my performance over the span of some training intervention. And there is both educational support and technical support if you have challenges with the app. This one program is new. It's called Couch to 7. And the idea of this form of the workout is to take people who are very sedentary and then try to get them to become active enough that they can lower their A1C to 7%. This is really designed for people living with type 2 diabetes who have not been very active and they have their A1C above target. And this workout is geared towards bringing the glucose down and in fact achieving a target A1C of 7% by the time this several week exercise program is completed. And it's very engaging and quite motivating. For me, if I do a workout with this app, I'll just enter in my glucose either manually from a self-monitoring of my glucose, or it'll be streaming in with CGM, and it'll just recommend a type of exercise to start with if my glucose happens to be on the high side, like when I entered in here that my glucose was at 200 milligrams per deciliter, or around 11 millimole. And it then recommends an easy warm-up so that I don't overexert myself at the high blood sugar level, with a target heart rate zone between 50 to 70% of the maximum heart rate, which is quite mild. And this is going to be in the fat burning zone, but also facilitate a bit of glucose disposal so that my glucose comes back down under control. And I like this app because it then educates the user both with video, but also with text on what type of exercise you'll be doing and what your goals should be for the effect on your glucose. Now, of course, exercise comes in all sorts of different forms, and many of these videos I just highlighted show that there are all sorts of different things you can do with respect to exercise, and they have differing effects on glycemia, which is what I'd like to transition to next. Many of the activities that are done by patients are aerobic in nature. The more common activities include walking, jogging, cycling, maybe swimming. And these activities typically cause glucose levels to drop. But some patients are doing more intensive activities that are anaerobic in nature, or strength training activities. And these tend to push glucose levels up. And I'll explain why in just a few minutes behind these differences in their metabolic responses. And of course, some activities are a combination of aerobic and anaerobic, and they tend to have a moderating effect. Just mentioning briefly that flexibility is quite critical for diabetes. We know that with diabetes, there is glycosylation of the ligaments and tendons if glycemic control is suboptimal, and this can increase risk for injury, joint pain, and joint stiffness. So adding flexibility exercise is also quite critical for people living with type 1 or type 2. Now, these different exercise systems tax our glucose stores in the body, and I just wanted to remind you that glucose is stored in a few different places within the body. There's some glucose stored in the liver in the form of glycogen. We have maybe 100 grams worth of glucose stored in a liver that is topped up after a carbohydrate-rich meal. We also have some glucose stored in the muscles. We may have 400 grams of stored glucose in the form of glycogen. And these large reservoirs are really what we count on during exercise because they will gradually deplete. What we don't want to count on is the blood sugar during exercise. You can see here that there's very little glucose stored in our bloodstream. If we have a normal glucose concentration of, say, 5 millimole or 90 milligrams per deciliter, that equates to only 4 grams of glucose. So we need to tap into these carbohydrate stores, and we do this by lowering insulin administration for aerobic exercise, and that's critical. Because if we rely on the glucose in our bloodstream, we'll use up those 4 grams in a matter of minutes and hypoglycemia will develop. So transitioning to some of the physiology behind this, think about the different forms of exercise that patients do, and then think about the general trends in glycemia. Patients who are doing an aerobic exercise event, cycling, jogging, rollerblading, even walking, where the power output is fairly constant, but not too high, something they could sustain for 30 minutes or more, we tend to see a drop in glucose concentration over time. Some patients drop more than others. There's patient variability here for unclear reasons. Maybe it's fitness level, maybe it's onboard insulin, maybe it's muscle mass, we're not too sure. On the other side of this extreme, there are purely anaerobic activities. Patients who do mixed martial arts, weight training, taekwondo, powerlifting, we tend to see glucose levels rise. And again, there's patient variability behind this, which I'll come back to. And then finally, these activities in the middle have a moderating effect, and that's why it's beneficial to recommend mixed activities where there's intervals of aerobic, moderate intensity effort, but then high bursts of anaerobic activity like a basketball game or a soccer game or a high intensity interval workout, because these little cycles in between moderate and hard cause glucose to often stay flat and are safer from a glycemic management perspective. And they're also quite beneficial from a training adaptation for the cardiovascular system and for the metabolic machinery. So glycemic control in athletes with type 1 diabetes, even though they have lots of experience, tools, and technologies, is still a bit of a challenge. One interesting observational study we published recently is we evaluated the glycemic control during a 7-day stage race during the Tour of California in 6 riders living with type 1 diabetes. And we had technologies, including CGM, where we could map out the glucose concentrations during the ride. Many of the riders started slightly hyperglycemic on most of the days, but then brought their glucose down to target quite nicely with the titration of carbohydrate feeding. We can map their heart rate out during exercise. We can get estimates of the power output during the cycling ride. And we can also measure other things like the temperature, the elevation of the climbs that they did, etc. With all of this data, we could then try to figure out why some riders were having better time in range than others. But in general, the whole cohort had pretty good time in range. The first day of the stage race, they had about 50% of their time in range. And as the race went on, they were wavering between around 78 to 60% time in range, which is not bad. A little bit of hyperglycemia, which often is associated with a pre-exercise elevation in glucose, almost as a protective mechanism, so that they weren't hypoglycemic during the race, because that would put them out of the race almost instantaneously. So how do they balance their glucose concentrations during a ride like this? Well, it's a combination of glucose that's produced from the liver that has to match almost perfectly equal the glucose that's being taken up in skeletal muscle. So on this cartoon schema here, you can see a number of different key organs. There are about 70 to 80 grams of glucose stored in the liver, which we can have enter into the bloodstream if the insulin drops during exercise. If the insulin doesn't drop during exercise, we can't get that glucose out. We also have the muscle, which has up to 800 grams of glucose in the form of glycogen, and the insulin concentrations do not impact the use of that fuel. It's just the exercise intensity that'll dictate that. So to maintain a glucose concentration of 5 millimole or 90 milligrams, which is what a non-diabetic glucose concentration would be during a bike ride, you have to somehow lower insulin and raise glucose. So this is very difficult to do in someone living with diabetes, because insulin's not delivered from the pancreas, it's delivered from either an infusion device or an insulin pen, and it's very hard to take insulin out of the bloodstream once it's been injected or infused. And there's also problems with glucagon not rising normally in type 1 diabetes, particularly if they have been living with this disease for more than 4 years. But this is what we try to simulate if we are trying to normalize glucose homeostasis, because a reduction in insulin and a rise in glucagon will cause glucose production by the liver to match perfectly glucose uptake into the working muscle, which does not require insulin, because muscle contractions can pull glucose in independent of insulin signaling. Now, for very intense exercise, there's a different mix of hormones. Very intense anaerobic exercise or intense aerobic exercise during a sprint race, for example, there's a rise in catecholamines. And this rise in catecholamines will dump glucose from the liver quite effectively. And in fact, it'll dump it at a faster rate than the muscle can take it up. So glucose levels typically rise. And when this happens, insulin secretion rises automatically in those who don't have diabetes. And again, this is very difficult to simulate in someone who has diabetes because we can't secrete insulin directly into that portal vein. So just to summarize, in diabetes, we often see insulin levels rise during exercise. And that's because once insulin's been injected into the subcutaneous tissue, exercise makes the insulin be absorbed much more quickly. This rise in insulin and this impairment in glucagon secretion causes glucose production by the liver to be limited, and glucose uptake into muscle exceeds production and glucose levels drop. With intense exercise and diabetes, we see a normal catecholamine response, and that again will cause increased glucose production that exceeds glucose uptake in the muscle. And sometimes we do have to administer insulin if glucose levels rise, but I'll caution you about that because we may see late onset hypoglycemia, particularly if this event occurs later in the day. So you might wonder how to assess this threshold of glucose rising. And you can assess this by something called the breath sound check. We think that these shifts in risk for hypo and hyper occur at the lactate threshold, which can be somewhere around 70 to 80% of someone's maximum aerobic capacity. If you're at this threshold, you typically have difficulty talking during exercise. So think about yourself going for a run or a bike ride. If you carry on a conversation, when you're doing this, you're probably below this threshold. You're in the aerobic zone and you have a higher risk for hypoglycemia. If you can no longer carry on a conversation because the work is too difficult, you're probably on the higher side of this threshold and the patient would have a higher risk for hyperglycemia. So using a talk test or a breath sound check is often one way to know whether you're at this lactate threshold because we often don't measure lactate unless we do experimentally. There is, however, a lot of patient variability around the glycemic responses to exercise. In one study of 121 youth with type 1 diabetes, all asked to do 45 minutes of purely aerobic exercise at the same relative intensity, you can see that they all start off their exercise with varying glucose, pre-exercise glucose concentrations ranging anywhere from around 60 milligrams per deciliter up to around 350 milligrams per deciliter. And the drop in glucose is quite varied. You can see here that some individuals are having a very small drop in their glycemia, just a couple of milligrams, where others are dropping 200 milligrams for that same relative exercise effort. We color-coded in this study in red the ones who developed hypoglycemia during that 45-minute worth of aerobic exercise, and it was almost a 40% hit rate. So in other words, you've got a 40% likelihood of developing hypoglycemia during a 45-minute aerobic exercise session if you haven't had any insulin dose adjustments or if you haven't initiated carbohydrate feeding. It's also important to note here that many of the youth with type 1 diabetes, although they were overtly hyperglycemic prior to exercise, this did not make their glycemic control worse because in fact, most of these kids had a drop in glucose and it brought them down towards a more targeted range. So we used to think that exercise was contraindicated in diabetes if blood sugar was elevated, but this data and others show that that's not true. We can now exercise as long as we're not producing high levels of ketones, even if we are slightly hyperglycemic. Glucose certainly can rise with intensive exercise, and we do see this particularly in the morning in a fasted state. So if you have patients that like to do a morning workout at a very vigorous intensity, we often see glucose levels rise in these individuals. In one cohort of adults with type 1 diabetes, we brought them in on 4 occasions. They did a morning workout that included 3 15-minute bouts of very vigorous exercise, and all of the patients had a rise except for one. And the rise was quite significant. Before breakfast, their glucose was sitting at around 7 or 8 millimole, and after the workout, before breakfast, their glucose was in around 12 millimole. So that's a pretty significant rise. And there was patient variability. Each dot here or triangle represents an individual, their rise in glucose during the workout. And you can see here that many individuals had a very high rise in glucose and other individuals had a more moderated rise. But there was some reproducibility when we did it on 4 repeat occasions. And it seemed to be linked to the individuals who had the highest lactate responses to exercise. They tended to have repeatedly the highest rise in glucose. So three key things about exercise type. Low intensity exercise, glucose typically drops. High intensity, short, sharp bursts, glucose may rise, particularly if it's done fasted. And mixed exercise are the best because they tend to have a moderating effect. And we often recommend, therefore, if glucose is on target, to do some resistance exercise first and then transition to aerobic so that your glucose stays flatter. Of course, if your blood sugar is quite high, you could start with aerobic first and bring it down to target and then shift over to resistance or anaerobic work. And then finally, just remember that each patient is a little bit different, but there's some level of reproducibility within that individual. So whatever plan works for them should work consistently. Okay, I'm going to move on to the carbohydrate and insulin dose adjustments so that we can mimic the normal physiology better with the different types of exercise that we just talked about. First, I'll just share this table with you. It is what to do as a starting point based on the initial blood glucose concentration or the initial sensor glucose concentration. If the glucose is a little bit low, have some carbohydrate, particularly if you're going to do aerobic exercise first. If it's in a targeted range, a small amount of carbohydrate is recommended if you're going to do aerobic exercise first. But if you're going to do anaerobic or resistance first, you're okay to start because your glucose probably will stay flat or rise just a little bit. If the glucose is above target, say between 10.1 and 15 millimole, it's okay to start aerobic. But the glucose should drop, and some athletes say that their performance is compromised if their glucose is too elevated. They feel sluggish. Again, anaerobic exercise may make that worse because the anaerobic exercise may cause the glucose to rise more and they might feel like their performance is dropping. If the glucose is over 15 millimole or 270 milligrams per deciliter, we recommend to check for ketones. If the ketones are trace or negative, it's okay to start aerobic exercise. If the ketones are positive, you would delay exercise until you can restore ketone levels with some insulin. And just a quick note of caution that some patients on SGLT2 antagonists have elevated ketone productions even in the face of only modestly elevated glucose. And if patients are on SGLT2s, it's critical that they check their ketones before exercise because exercise often makes the ketone production increase. Now, simply stated, there is a time of day in which exercise is quite safe, and that's right after a meal. So if you look at patients either with type 1 or type 2 diabetes and you ask them to exercise at the largest meal of the day, what you typically see is that their glucose excursion is less and there's no hypoglycemia or hyperglycemia. In this one study, they examined the glucose excursion associated with staying sedentary after a large meal. Glucose is rising 6.5 millimole, and then that same meal, they do 30 minutes of walking, and they see that the glucose excursion is lower. So that's a very safe time to exercise. You don't have to do anything other than put on your walking shoes and go for a walk. You don't need to adjust your insulin. You don't need to take carbohydrates. And the same is true for type 2 diabetes. If you just do a 20-minute walk after a meal, you're just going to have a less of a glucose excursion. So this is a great time to add exercise safely and effectively for glycemic management. Doesn't require any manipulation in insulin dosing or carbohydrate feeding. So again, less than 60 minutes right after a meal, typically no change required in therapy. If the exercise lasts a bit longer, however, it's good to have carbohydrates handy because if you drop below target or close to target, you might need 10 to 20 grams of carbohydrate to maintain your glucose for that given activity that lasts up to 45 minutes. Now for endurance performance, typically for your athlete with type 1 diabetes, they need more fuel than just the fuel that supports, that prevents hypoglycemia. They need fuel for the working muscle as well. So the prescription typically is between 0.5 grams of carbohydrate per kilogram body mass per hour up to 1 gram of carbohydrate per kilogram body mass per hour. And that would support both glycemia and performance requirements. Typically what elite level athletes with type 1 diabetes will consume for endurance and ultra endurance events. Now, too much carbohydrate may not be desirable for some of your patients living with diabetes who are on insulin because they may be trying to lose weight. So it's often better to consider in these patients an insulin dose reduction rather than carbohydrate feeding. It can be very demoralizing to have a workout in which you expend, say, 200 calories, but then you had to eat 160 grams or 160 calories worth of carbohydrate to offset hypoglycemia. So many patients will simply do a pump disconnect or insulin pump suspension for aerobic exercise. And this, although intuitively sounds like it should work, it's not that effective. And that's because insulin suspension at exercise onset doesn't take insulin out of the bloodstream. In fact, as soon as the person begins exercising, the insulin concentrations often rise because of increased blood flow to the subcutaneous tissue where the insulin depot lies. And what we see typically is glucose levels will still drop markedly in people who do insulin suspension at exercise onset. If they do aerobic exercise in this study, glucose levels still drop markedly even though there was no infusion of insulin during exercise. And many of these individuals still develop hypoglycemia. It's better really to shift the type of exercise that these patients do with pump suspend. They could do more of a circuit-based or interval-based exercise to increase the likelihood that they are producing lactate and some anaerobic metabolism, and then the glucose won't drop as much when that pump is off. So taking the pump off or disconnect, it's fine, but it just may not prevent hypoglycemia altogether. So in these settings, even if the pump is off, it's often required that they consume some amount of carbohydrate, particularly if their pre-exercise glucose is on target or a little bit on the low side. And the prescription here is around 0.2 to 0.3 grams of carbohydrate per kilogram per hour. So it's not a lot of carbohydrate. For me, someone who weighs around 80 kilos, that's only around 17 grams of carbohydrate for an hour's worth of exercise. So it's not a lot, but it's just enough to prevent hypoglycemia if I'm exercising with pump suspension. A better approach might be to consider the timing of exercise and try to lower either the basal rate before exercise or to lower the bolus insulin before exercise. So let's take a look at a couple of examples. In the first one, the patient would like to exercise about 1 to 2 hours after a lunchtime insulin injection. So if this first curve represents the bolus insulin administration on an inactive day, and then we contrast that to bolus administration on an active day, the patient would cut the bolus by 50% so that the aerobic exercise and the diminished insulin together would bring glucose under homeostasis. So again, if the exercise is 1 or 2 hours after a meal, cut the bolus by 50%, adding aerobic exercise, and you'll have good glucose stability. If, however, the exercise is not in that time window of 1 or 2 hours after a meal, it's later or before, then it's a basal rate reduction that the person should target if they're on an insulin pump. In this example here, the person has a normal lunchtime bolus of insulin. They turn the basal rate down by 50%, 1 hour before the start of aerobic exercise. They keep that basal rate reduced for exercise and then resume it when the exercise is done. And those studies have been shown to be quite effective in limiting the drop in glucose during exercise. But it has to be well thought out. The person has to remember to do that basal rate reduction an hour to 90 minutes before exercise. At bedtime, there's also another stepwise temporary decrease in basal insulin delivery for those on open loop pumps because there is heightened insulin sensitivity overnight. So there's a reduction by 20% lasting for 6 hours at bedtime. And then again, if they don't remember to do this, they can suspend their basal insulin during exercise, but they probably require some carbohydrate feeding, somewhere around 0.2 grams per kg per hour. Just one quick look at a study that looked at this temporary basal rate set well before exercise. A paper published last year in Diabetes Care took a group of athletes with type 1 diabetes, and they did pump suspension at exercise onset, shown in black. Glucose levels still dropped. Many still developed hypoglycemia. That same cohort came back on another occasion and did basal rate reduction 90 minutes before exercise, shown in red, and there was much less hypoglycemia and less of a glucose drop. That reduction in insulin delivery that was 90 minutes before exercise and all the way through exercise did not appear to compromise their glucose control in the next meal, which is good. So using CGM during exercise is an added safety net, and of course, when you have lowered your insulin already and you don't expect to see your glucose to drop, and sometimes it still drops, you need to have some carbohydrate readily available. And we've published this algorithm that suggests when you should take that carbohydrate. And basically the threshold's at around 125 milligrams per deciliter, roughly 7 millimole. When glucose drops below 7 millimole and you're doing aerobic exercise, you need to be on the lookout for your trend arrows on your CGM, because if they begin to drop, that's when you have to initiate carbohydrate feeding. In this algorithm, if glucose is between 111 and 125, so it's a little bit on the high side, but it's dropping with 1 or 2 downward arrows, 8 grams of carbohydrate will prevent hypoglycemia. If glucose is a bit lower, between 90 and 110, but still on target, if glucose is dropping rapidly, it's 20 grams. If it's not so rapidly, it's 16 grams. And if glucose drops below 90, even though that's not biochemical hypoglycemia yet, we still recommend taking 16 grams for the prevention of glucose from dropping any further. Now, I'm going to talk next about hypoglycemia after exercise. The DirectNet study was one of the first to show quite nicely that if you develop exercise-induced hypoglycemia during the day, particularly if it's in the afternoon, there's a great likelihood that you'll develop nocturnal hypoglycemia overnight. In this study of 50 children with type 1 diabetes, they had quite a few kids who developed a drop in glucose and hypoglycemia during exercise, and then about 50% of that cohort developed nocturnal hypoglycemia. So there seems to be this phenomenon in which if hypoglycemia occurs during exercise, there's greater risk overnight for a second hypoglycemic event as the counter-regulatory systems break down or as the muscle and liver glycogen concentrations are trying to be topped up. It's a bit unclear which that is, or it could be the combination of the two. So I like to think about using CGM as your warning symbol if your glucose is dropping during exercise and overnight. And this is a blinded CGM from a very early study using blinded CGM. And we can see in diabetic athletes that if they develop hypoglycemia in the afternoon with exercise, as was done in this particular study, they often develop nocturnal hypoglycemia overnight and didn't know that they were developing it because they didn't have the alerts and alarms for these retrospective CGMs at the time. Non-diabetics have very small fluctuations in their glucose throughout the day, and we didn't see much hypoglycemia in the non-diabetics when they did the same form of exercise. So we think what's happening is with these exercise bouts in the afternoon, the glycogen is being depleted in a relatively quick fashion, and then during the night, that glycogen has to replete back up, and that's why glucose is dropping in the bloodstream as that muscle glycogen and liver glycogen are recovering. We sometimes see it even in athletes that aren't going hypo during the exercise. This is a hockey game with a blinded CGM on a young hockey player, and although his glucose rose during that competitive game, he still developed nocturnal hypoglycemia symptom-free overnight. So we have to watch for it no matter what form of exercise they do, aerobic, anaerobic, or mixed. We often see nocturnal hypoglycemia. And that needs to be dealt with either a basal rate reduction overnight, if it's on a pump, or carbohydrate feeding, which would include carbohydrates at around 30 grams with some protein and fat to make it stretch over the evening. Now that rise in glucose that we talked about before is another problem if it occurs in the early morning, because in the early morning, if the glucose levels rise, it sets them up for failure for the rest of the day. They end up being high for their breakfast and for their lunch. So in a follow-up study to this one, we decided to either not treat the individuals who had a rise in glucose with morning fasted exercise, and we watched their glucose levels stay elevated for several hours in recovery. And in those same individuals, we brought them back on repeat occasions, and we gave them insulin corrections that ranged from a 50% insulin correction, a 100% insulin correction, and 150% insulin correction. And although we could get the glucose down more and more aggressively with the larger correction factor, we did increase the risk for hypoglycemia. So the take-home message with this is that if you do see hyperglycemia in the early morning, you can treat it aggressively with insulin, and we're recommending a 50% bolus insulin correction to try to bring them down before their next meal. Too much insulin will probably result in hypoglycemia some 6 to 11 hours later. So it's just a conservative insulin correction. We do see this nocturnal hypoglycemia even in the Team Novo Nordisk riders. I showed you this data already, which is the daytime ride, but I'll show you the CGM values overnight. Again, this is a 7-day stage race where they were cycling some 5 or 6 hours a day, and their glucose control was pretty good during the day. But when we monitored their glucose overnight, we saw there was considerable nocturnal hypoglycemia that seemed to be getting worse rather than better as the race went on throughout the 6 days. So we know that nocturnal hypoglycemia is common. Anything above 4% time below target is considered dangerous, and these athletes were averaging 17% time below target. And because they were all on MDI, we had to resort to nutritional strategies in the next race to eliminate this, which we did a good job of. The data is not shown here, but they all could eliminate that nocturnal hypoglycemia by having a bedtime snack that included some carbohydrate, protein, and some fat. For those on pumps, you can lower the insulin overnight. This one study showed quite nicely that using a closed loop design, you need about 20%, maybe 30% less insulin overnight. And that algorithm automatically took care of that. So insulin pumps that are on closed loop mode tend to keep glucose levels normal overnight after exercise because they drop the insulin delivery because of the perceived improvement in insulin sensitivity caused by exercise. If you don't have closed loop design, then you need to set that as a temporary basal rate reduction by 20% for 6 hours overnight to try to eliminate hypoglycemia. So just to summarize, we've highlighted 3 very common challenges today in this webinar. The first one is hypoglycemia during exercise and recovery. We talked about the mechanism where aerobic exercise increases insulin sensitivity and hepatic glucose production is suppressed because insulin is too high. We talked about adding carbohydrates as one possible tool, and there's the prescription here, up to 1.5 grams of carbohydrate per kilogram per hour in those who are in performance mode. And for those who are not in performance mode, you may get away with a little bit less, particularly if it's longer after a prandial dose of insulin. It may be 0.3 grams per kg body mass per hour. And the type of carbohydrate is often a low glycemic index carbohydrate if it's 1 to 4 hours before exercise, or a high glycemic carbohydrate if it's during exercise. For insulin adjustments for this problem, we talked about reducing the bolus insulin if it's soon after a meal. And we also talked about doing a basal rate reduction if it's 3 or more hours after a meal. And that basal rate reduction needs to be initiated 60 to 90 minutes prior to the start of exercise. And we also talked about adding other types of exercise that will help support blood sugar levels, including sprints or intervals or resistance training that'll help flatten out the glucose. And we talked about the advantages of using CGM technology and sensor augmented or hybrid closed loop pumps to help manage this. We also talked about hypoglycemia on nights after exercise. We talked about why that occurs, and we touched briefly on adding carbohydrate as a snack at bedtime along with some protein and fat, and we talked about some insulin basal rate reductions overnight. For those on MDI, you can also consider lowering the basal insulin analog by 20%, but you should often also add a snack. And we also talked about the advantages of having real-time sensors to help provide alerts and alarms overnight. And that sensor augmented pumps do have an advantage in protecting against hypoglycemia overnight. And then finally, we talked about hyperglycemia after exercise, and that seems to be related to the increased production of lactate and counter-regulatory hormones. We talked about a conservative insulin adjustment if it's in the morning, 50% correction factor, for example. And if it's later in the day, we probably should focus on some other strategies so that we don't increase hypoglycemia risk overnight, such as doing some aerobic exercise in a cool down setting. So just to summarize the webinar today, exercise is critically important for all of us living with diabetes, whether it's type 1 or type 2. We should be aiming for 150 minutes per week or more of accumulated aerobic exercise with resistance exercise 2 to 3 times per week. The glucose response to exercise depends on several variables, but in general, aerobic exercise tends to cause hypoglycemia, while anaerobic exercise tends to promote hyperglycemia. Hypoglycemia can be prevented with carbohydrate feeding and or insulin dose adjustments. Bolus reductions are best selected when the exercise is soon after a meal, 1 to 2 hours after a meal. Basal rate reductions can be done 90 minutes in advance of exercise that is going to be 3 or more hours after a meal. And finally, hyperglycemia can be managed if it occurs after intensive exercise by providing a conservative post-exercise insulin bolus, or in other words, a 50% correction bolus. But be cautious with this because it may increase the risk for late-day hypoglycemia, so it's not recommended if the exercise is close to bedtime. Thanks very much for your attention for this webinar. I certainly hope you learned something, and please feel free to reach out by email if you have any specific questions that you think I might be able to help you with. Goodbye.